So good afternoon. Today is Wednesday, January 10th, 2024. Happy New Year, everyone. And welcome to the fifth of 8 sessions in our IPRO Echo series entitled When the Pain Won't Stop, Whole Person Care Addressing Chronic Pain. And we have excellent conversation for you today. Dr. Berlin will be talking about tips and tricks of non-opioid analgesics. And then we have a case presentation that will be presented. Tosin will facilitate it, and Tom Bowen, sorry, Tom, will be presenting a case for us. And then the third part of our session is with Daniela Deutsch, and her topic is integrating pain reprocessing therapy into your practice. And this is a follow-up to the December presentation by her colleague, John Gasenica. So we're really excited to have kind of part 2 for that series. Next slide, please.
Sorry, Lynn, it doesn't seem to be advancing for me here. There we
go.
Back.
If anyone
went back to the welcome slide, so give me one moment here.
Okay, no problem. So I will just say if anyone has any technical needs during the presentation, you can contact Lynn Smith at the email that you see there, or call her at the phone number that you saw, and we'll see again. And just a little background about the IPRO QIN-QIO. We are a federally funded quality innovation network, quality improvement organization. We're funded by CMS, and we work in 11 states in the District of Columbia. We collaborate with 2 partner organizations, other QIOs, Health Centric Advisors and Clarent. And on the picture that you will see in a moment, you will see that the states that we work in, but it's basically all of the New England states, New York, New Jersey, Ohio, Maryland, Delaware, and the District of Columbia.
I'm sorry, Lynn, it's showing the wrong slides here. So
that's at the end of the deck, Carolyn.
All right.
Go back up. Yeah, it's good. Oh, that's the welcome.
This is the welcome deck that it's showing. So I'm going to need to pull it up again from scratch. So why don't you continue, and I'll pop it up as soon as I can.
I will do that. Yeah, no problem.
The slides.
Yeah, no problem. The IPRO QIN-QIO partnership for communities health focus that this ECHO is addressing is reducing opioid-related adverse drug events. So obviously we think that one of the simple ways to reduce opioid adverse drug events is to not have people needing to have a prescription for opioids, but there are many other parts to that as well. Also, our agenda today, we've already gone through that. I just want to remind you of some of the ECHO etiquette. Carolyn, are you doing okay?
Yep, I believe it's coming up.
Okay, I'm on slide 6.
Okay.
Yeah, thank you. Perfect. So we do encourage people to turn on their cameras as you're able to, just because it helps us see who's here and see one another. And let's see, hold on. Let's try to get the slides.
Yeah, when I go to presentation mode, for some reason it's pulling up the other deck, even though I have it closed. So I'm not sure what that issue is.
Okay.
So what slide number are you on, Lynn?
6.
And are you seeing slide 6 now?
I do see slide 6 now. Yay.
It is. I'm just a little concerned about putting it back in presentation mode, because that seems to be what's corrupted for the moment at the moment.
Is this okay for everybody? Can you all see? Is this tolerable? People are shaking their heads. Yes. This is another reason why it's nice to have your cameras on, so we can just get that nonverbal validation. Okay. So most of you have been here before. Use your camera, mute when you're not speaking, raise your hand if you want to speak, and clearly, as always, no PHI. And on the next slide is just some reminders about HIPAA, muting mics, etc., things I just said. On the next slide is to obtain your CEs. I assume if anyone's having any challenges obtaining CEs from these sessions, please drop me a note in the chat or Tosin, and we will support you with that. But you do need to complete the sign-in sheet that Tosin will put the link once more in the chat for you. You must complete that sign-in sheet, and then you must complete the evaluation that will be sent. The link will be put in the chat at the end. Okay, next slide. So today's presenters, we have back Dr. Dan Berlin, who is proudly from the University of Michigan. We'll probably talk about the football thing there. And he is board certified in internal medicine and addiction medicine. We also have Danielle Deutsch, who is coming to us. She's a co-founder and content developer and lead trainer at the Pain Reprocessing Therapy Center in Los Angeles. And she does wonderful work. Really excited for you to hear what she has to talk about. And then you have our usual cast of characters. Tosin is here, pharmacist. Rosie and Janice, both patient advisors, myself and Carolyn Kasdan. So, and the next slide is the disclosure statement slide. None of us have disclosures to make with one exception, and that has been mitigated, and there is no conflict of interest noted for Daniela. So having said all of that, I now would like to turn the slides over, or the presentation over to Dan to talk about managing non-opioid medications, tips and tricks. Dan, it's all yours.
All right. Hi, everybody, and Happy New Year. I will show you again. Very proud here. There were many fires set in Ann Arbor to celebrate. I guess that seems to be the way things are done around here. They like to burn mattresses and furniture, but there has been legitimate celebration. And yesterday in clinic, many people had on improper garb. What is this? Oh, good grief. Get rid of my phone. Thank you very much. Anyway, we will drown in our championship and rebuild next year. Next slide. So, as usual, my talks are generally for prescribers. So for you non-prescribers, hopefully I won't bore you to death, but at least you'll be able to know what the prescribers should be doing. So anyway, today we're going to talk about medications, because what do people do except make diagnoses and start prescribing things? And we've spent a lot of time talking about why prescribing is really only a part of treating chronic pain, but there can be a role for medications, and we'll start with non-opioids, and then after this we'll get into opioids. Lynn, you'll be happy to know that I've already put together the slides for next week, so I'll send them to you later today. Bravo. So these are the objectives. I won't read them to you. I only have a few more slides, but I'll be doing a lot of talking. Next slide. So if anybody has any questions, just unmute and start asking, because we're supposed to be kind of interactive here. So I'm going to talk about the various classes of non-opioid drugs that may have a role, may be toxic, and how to prescribe them and de-prescribe them, because a lot of times people will not give people what I would call a correct or fair trial for something that might actually be helpful. And then, of course, is there a role for polypharmacy? Because usually chronic pain patients, especially the more disturbed they are, end up on a whole lot of drugs. So we'll start with Tylenol, acetaminophen. Everybody gives it. The literature for it as a synergy drug with, say, hydrocodone, so think Vicodin or Norco, is actually quite slim. The literature for it is a single agent for treating somatic pains like arthritic knees is quite slim, but everybody prescribes it. It's not totally non-toxic. It may actually cause bleeding almost as much as aspirin does. But it's certainly effective for headaches. NSAIDs, on the other hand, do have some literature, at times robust literature, to support them for treating pain generators, particularly of arthritic origin, as well as headaches. But they can be limited by toxicity. So when given orally, if people develop a stomach ache or dark stool suggesting GI bleeding, that could be a problem. There is some question about long-term use and renal disease. It's uncommon, but it occurs. It can cause acute renal dysfunction occasionally. So NSAIDs have their issues, but they're low cost, they're often over the counter, and can be effective. One thing that people forget about with NSAIDs is in acute pain, when given parenterally, they're actually equally effective to opioids, and most people don't seem to know that. In head-to-head trials, IV or IM ketorolac, that's Toradol, has been found to be as effective as up to 10 milligrams of IV push morphine, which is a pretty considerable dose for an opioid naive patient. So just something to remember. I know I treat all of my chronic sickle cell patients who are not opioid free between sickle cell events. Most of them are on buprenorphine, not other opioids. And if they have an acute exacerbation, I often will treat them with IM ketorolac that they use at home for a few days and do great and never come to the hospital. And this seems to be a secret. So anyway, so let's move on to the next category, because now we start to talk about treating neuropathic pain. Neuropathic pain is notoriously difficult to treat. Some medications in 3 different categories have been described as being somewhat effective. As usual, I would say perhaps in a third of the patients or less, may reduce pain scores by 50% or less. So can be helpful. I'll start with SNRI agents. So that basically means Cymbalta, duloxetine, venlafaxine, which is Effexor, has some supporting literature, but not much. People have touted milnacipran as another agent that can be effective. I've actually seen trial data showing it no more effective than placebo. So duloxetine is kind of by itself. It could be used as a first-line agent for neuropathic sounding pain, but it turns out it also has some effectiveness even in trials related to nonspecific low back pain. And it may be independent of its mood elevating effects. It certainly is worth a try in people who have co-occurring depression or anxiety. You can treat both at once and try to keep down the polypharmacy. Most patients who are treated with duloxetine need doses that are higher than the antidepressant doses, so meaning more like 60 to 90 milligrams a day given once in the morning. Going above 90 milligrams is probably useless and may only increase the potential toxicities of duloxetine that include things like urinary retention. So moving on to the next category, we've seen a huge rise in the prescription of gabapentin and pregabalin as people try to avoid opioids. And the prescription of these drugs is very questionable outside of what sounds obviously like neuropathic pain. So radicular distribution, burning or tingling symptoms, but for generalized pain or back pain, there's no trial data to support that for acute or chronic pain. but we see it prescribed all the time. I will tell you that Pfizer was fined hundreds of millions of dollars for false marketing of gabapentin over the years. I've seen patients on as much as 7,000 milligrams a day of gabapentin, which is an astonishing dose, basically showing why it's a controlled medication because it can be abused. So these days, we're still seeing a lot of gabapentin prescribing. I would argue maybe we should see pregabalin prescribing, pregabalin being a little less toxic in most patients. Often you can get away with BID, sometimes TID dosing, not QID dosing. And now that it's generic, it's quite cheap. And the doses are usually like about 1/6 the gabapentin dose. So when giving these a try, and they can be worth a try in at least fairly purely sounding neuropathic pain, people should be rapidly titrated up. I'll see people started on 100 milligrams and we'll see you in a month. That's ridiculous. Often people should be started at 300 milligrams at night. And after a couple of days, if it hasn't put people to sleep or made it hard for them to speak, then it should go to BID, and then after 2 or 3 days to TID. So rapidly titrating people up to 900 or about 150 in divided doses of pregabalin. You can then have the patient check in, and if there's a partial benefit, no toxicity, take it up to 1,800 milligrams a day, or 300 of pregabalin divided into 3 doses. And you'll see people go higher. The drug companies certainly wanted people to go higher, but most people don't benefit much going beyond that dose. Occasionally it's worth a try. If the drug's toxic or not effective, within a week or so, and it can be tapered off by cutting down 1 capsule a day until they're off. Topiramate is listed here because it's potentially a first-line agent for migraine prophylaxis. But again, this is a highly toxic drug, probably should not be used in other cases of so-called neuropathic pain. It's best given once at night, probably 100 milligrams or less a day, to avoid the toxicities of people feeling like they're stupid. That's why a lot of people, the brand name is Topamax, and we used to call it Stupid Max because everybody felt like they were demented when they took it. And it can make it hard for people to speak. I've seen people tolerate it with no side effects on up to 400 milligrams, but again, I do not prescribe this drug outside of migraine prophylaxis. Any questions about all this so far? Moving on to tricyclics. Thoughts on safety of TCA in the elderly. So I am just moving on to that now. So tricyclics can have a role, especially if you're co-treating. Oh, by the way, gabapentin or pregabalin might have a role in people who have hot flashes, but usually they develop tolerance to them, and the doses are usually low, not more than 200 or 300 milligrams of gabapentin a night. But again, we see tolerance to it, so people have to be withdrawn and restarted, so it's not extremely effective. As far as tricyclics go, again, if you're trying to co-treat anxiety or depression, they are first-line agents for that and for panic disorder. In the case of migraine prophylaxis, again, they're first-line agents along with beta blockers or topiramate. For generalized pain as a tertiary treatment in late-stage cancer pain, or for neuropathic pain, again, there's a role to try them out. Most people write for amitriptyline, Elavil. We usually tell people to throw the Elavil pens away and prescribe nortriptyline. a close relative that's less anticholinergic, meaning less sedating, less urinary problems, less dry mouth. But in head-to-head trials with amitriptyline generally have been shown to be equal at equal doses. So nortriptyline often can be started at pretty low doses for elderly patients, like 10 milligrams, and titrated up. For normal sized younger adults, 25 milligrams. And again, you don't take forever to titrate this up. You can go up by 25, or if you started at 10, about every 4 days, and titrate up to sleep effect if people have sleep problems, or side effects. And if they reach a point where they're sleeping okay, now the pain effects may take a couple of weeks, and so you've got to wait to see if there's a benefit. If it's a toxic drug, it should be discontinued, not just left there. When should it be given? Most people were trained that they should give these drugs at bedtime. That's usually not a great idea. It's actually often better to give them at dinner time, another well-kept secret, because it can allow you to titrate the doses up a little higher, but they can still get out of bed in the morning. And for those who have problems with sleep initiation, they can often fall asleep better. And so I usually tell people to take them around dinner time, unless they have to take them a little later because they're falling asleep too early. To answer the question about using them in the elderly, yeah, these are considered Beers troublesome drugs, in the Beers criteria. But again, if titrated carefully and there's communication between the prescriber, they can have a role. Because these drugs generally are only effective maybe a third of the time, or toxic, half the time, a lot of people aren't going to remain on them. There is some evidence that low doses of the anticonvulsants and tricyclics can be combined and taken synergistically. I've seen a couple of papers on that and have been known to try that out. How much time do I have, Lynn? Am I running out of time?
Yeah.
Okay, so I'm almost done. Muscle relaxants are frequently prescribed in acute or chronic back pain. There's no guideline that supports that, unless people are twisted up like a pretzel. They're usually sedating, can often have side effects. That would particularly include things like scalaxin and Flexeril. So once in a while, if you want people to sleep, that might be a reason to prescribe those drugs. But if they want to be functional, they're usually not useful. I see a lot of baclofen prescribing. Baclofen is for spasticity, not for muscle spasm, and shouldn't be prescribed. It's basically kind of a benzo analog. And people should not be prescribed benzos. You have to be basically comatose on Valium before it's much of a muscle relaxant. That leaves topical agents. A lot of people are prescribing the over-the-counter 1% diclofenac gel, which really is no more effective than placebo. It was prescription, now it's over-the-counter. The 3% is effective, and there's trial data to support it. It used to cost about $1,000 for a 100-gram bottle. Now it's about $50. So it can be worth a try. And I will go to the next slide, which basically says this issue of synergy. People have prescribed acetaminophen and NSAID. The Russians have done it for years. There is actually supporting data for that, so that can be useful to try. And finally, for people who do have significant sleep problems, you can try doxepin, which is one of the few FDA-approved agents for sleep, a tricyclic, but it doesn't really have the same supporting data for it as a pain agent. And with that, I will stop.
Questions for Dan? That's a lot of information. I feel like there's some new information for some of you all.
Lynn, I had one question. Aside from the generic, what are the risks and benefits of a particular order that you're given as a patient? What should we be teaching patients to ask their providers when they're given a prescription for a pain med like this?
I'm not sure I understand the question.
Are there things we should be teaching patients to ask when a doctor prescribes a pain med for them, other than, tell me about the risks and benefits of this treatment?
Not particularly that I can think of. I think a lot of times people prescribe and they don't bother to tell the patients the potential side effects. And it's certainly important for patients to know. Though I lecture the patients and I tell them to be in touch with me if they have any question or if anything goes wrong, I'd say most don't. They don't contact me, and they take them and they have side effects, or they quit them and they don't tell me, or they don't say, okay, I'm at this dose, what do we do next? It's really problematic. Portals don't seem to help. I'm curious about diclofenac at the patient level. Sodium base, is it possible? Wait a minute, let me open this up. That use of this can raise sodium levels. No, topical diclofenac doesn't really have any systemic effects at all. For people who prescribe oral diclofenac, Dolabid, it would not be any different from other NSAIDs, and NSAIDs can cause sodium and fluid retention, but they don't cause hypernatremia.
And Lisa.
Yeah, I've seen patients who have labile blood pressure who are taking chronic non-steroidals. They often don't associate that with uncontrolled blood pressure and elevation. So I often warn them that non-steroidals on a regular chronic basis may not be safe for them, that Tylenol could be a better option unless they're just taking it PRN.
Well, you're right. Salt and fluid retention can lead to blood pressure elevation, as can acute renal insufficiency. But again, the trade-off is whatever we give them or tell them they could try may or may not be effective or toxic.
A question, anything about you want to say about topical compounding prescriptions, efficacy?
Yeah, it's a big business out there. A typical cocktail is something like lidocaine, a tricyclic, sometimes ketamine. For the most parts, these are expensive, not covered by insurance, and can be worth a try, but rarely effective.
So thank you so much, Dan. We're going to transition. Oh, and if you all have other questions that you want to put in the chat, please do. And we're going to transition over to the case presentation now. And we'll give Carolyn. So during a case presentation, just a reminder, Tosin, sorry, I'm sort of walking over you here for a second, but you'll pick up after I say this, I'm sure, is that this is really based on your input in the evaluations during November and December, or November. You all really appreciate and like these case presentations, and so you really understand the value of all teach, all learn, and that is what the ECHO is based on. So Tom will present this case, and then you'll have the opportunity to ask some clarifying questions, something more information, and then we'll look at recommendations. So Tom, welcome and thank you. What is your question for the team to consider as you present the case, please?
The main question I have for the team is, how do I empower this patient who's living with chronic pain to take more responsibility for their pain management and self-manage the pain, rather than relying on me and other healthcare professionals on the team to fix him?
Great.
So that's my overall question. I'll give you a quick review of that person. It's a 65-year-old male who has daily moderate to severe pain. His pain journey started about 14 years ago following groin pain after orchiectomy and orchiopexy for testicular torsion when he was 50 years old. A fall and subsequent head injury 4 years later exacerbated his pain experience with widespread pain, neuropathy, and tinnitus. He has multiple pain diagnoses, including amputation neuroma, neuropathy, fibromyalgia, IBS, SI joint pain, migraine, osteoarthritis, and costochondritis. His comorbidities include diabetes, depression, anxiety, tinnitus, chronic fatigue, and sleep apnea. His scan results don't match his pain experience at all. He has a history of pharmacological and interventional treatment that has not resolved the pain. He has multiple psychosocial contributors. One of the big ones is perceived injustice. Uh, so, and then I guess again, the main question is, how do I empower this person to be more responsible?
Thank you. Questions for Tom? Comments? What do you wonder about this situation?
So what's the injustice part about?
He believes that his pain journey started because of a misdiagnosis for testicular torsion, and he was
Mhm.
pursuing legal malpractice, and he was focused on that perceived injustice during the first few years of his pain journey.
Yeah, I
And
was suspicious after hearing that opening line about groin pain after torsion surgery.
he
It's not
also
described as specifically neuropathic.
Daniela, what did you want to ask?
I wanted to ask, what does he believe is the cause of his pain right now? Because there's a lot of different symptoms. What does he believe is the cause of the pain?
he doesn't know.
Okay.
Can I ask a question? Is this man a veteran?
No,
And what is his social status?
he is married, was gainfully employed up to the time up until, was it 7 years ago when he filed for disability.
And now what does he do?
He's retired on disability.
Does
But I
he
mean,
have
what does he
life?
do with his day? What is his daily activities?
He spends a lot of time volunteering.
Is he ambulatory?
No, he's very mobile. He's very
It says he has
very
disability
active.
status. I'm not sure what you mean by how disabled physically is he? Is he able to be mobile? And the second question I have related to that is there documentation of a peripheral neuropathy secondary to diabetes?
I don't know the answer to the second question. I know he has neuropathy. Now, in terms of the mobile, he's able to function. He functions normally. He just wasn't able to handle the stress of the job.
Yeah, well, you hear about all this centralized issues, fibromyalgia, IBS, headaches in a patient with mood disorder. And I would question whether or not he had any kind of pain syndromes or significant mood disorder prior to the groin surgery, because I'm going to guess he did.
Yeah, that was my question. Behavioral health, is he getting any care or treatment for his depression? I think you said he had a history of depression.
He's had psychotherapy and a variety of pharmaceuticals before. He actually went through transcranial magnetic stimulation as well.
So he's currently not engaged in any kind of like talk therapy with ongoing therapists.
Not now. Not presently.
Does the patient have any spiritual affiliations?
No.
Any
That's interesting. It sounds like a disconnect. He volunteers, yet, you know, he's got all these issues and has disability. I wonder if he really does.
And what were to happen if he went off, like if he got better and then he lost disability, then what would happen? What would happen to him?
I'm not sure.
Of course, he's retirement age now. He can collect Social Security.
Right.
Yeah, he is at that age.
He has so many different descriptive diagnoses, like fibromyalgia, for example. It's like when there's so much pain all over the body, but you can't figure out where it's coming from. Then a lot of doctors will say, oh, it's fibromyalgia. There's like muscle soreness everywhere. He has irritable bowel syndrome, which is also just a descriptive diagnosis. It's like your stomach hurts all the time. And just like the amount of different diagnoses that he has points to there being some type of underlying issue that is not physical, that has to do with the misfiring of pain circuits in the brain. To me, there's so much evidence pointing toward that.
Oh.
I would agree with Danielle and go further with that and say that there's probably a less connection with his social world, so to speak, in context, and empowerment issues. He doesn't feel empowered himself, even in control of his own pain or his perception of it. I think sometimes when, like you said, Daniela, so many diagnoses are thrown at you, you sort of say, oh, okay, I guess I am those things. Rather than saying, what do I really value? What do I really feel is important in my life? And how do I feel empowered, or what makes me feel empowered? So that
Good.
might be some place to start, certainly with a spirituality component.
Yeah. And then your identity, I think for a lot of people who have chronic pain, it's like their identity gets so wrapped up in being a chronic pain patient. And then it becomes scary to even know who you are outside of this identity of being in chronic pain. And so figuring out who he is outside of that and then empowering him to get back to that and envision his life in a different way.
Does the patient give any updates about his case when he comes to appointments? Does he happen to express about that? Because that seems to be part of, as you said, he feels that he has experienced an injustice, and it seems to be maybe even feeding into all of this, his inability to move on or go forward or get better even. And I know in the healthcare space, we often don't have a ton of time, but perhaps even some elements of empathy or minor expressions of it could help him start to climb out of that and see, possibilities ahead of him.
Yeah, he's very focused on the pain, spends hours on the internet researching the pain, tracks the pain daily, has done that before. So he's very focused on that.
Sounds to me like he needs to watch Dan Claw's video that teaches patients about pain perception and tries to teach them to stop looking for somatic causes of their pain and how to have a purpose in life.
Is that it's not an all in their head video?
Yeah, I can put a link to it in the chat.
Okay. I think I'm familiar with that video, but yeah, he has done some great work.
Excellent. Any other recommendations that you all might have?
Lynn, I put this in the chat, but what really makes him happy, what really matters to him, and try to direct him to focus on that instead of looking at the internet and what makes him pain, what brings him pain, but what brings him happiness. I mean, I agree with Dan. It's kind of like he volunteers. He seems like he gets quite a bit of sleep. And yet he's focused on the pain, and maybe he, to direct his focus to what really is important in his life, what matters to him, what brings him happiness.
Is this who suggested that?
I'm a patient advisor, and
Okay.
and who deals with with quite a bit of pain in my life, but it's not what I have probably have never looked up pain on the internet in my life except for this kind of work, but never in to look up what kind of pain and what causes my pain always, because that just makes you depressed, and it brings you down to all kinds of paths, and it doesn't really help always. So I think it's important to look at what's really important. Does he he has a wife, he has does he have children, does he have grandchildren, does he love, what does he like doing, those kind of things.
Lynn, is this a good time for me to kind
Go
of
ahead. Yep. Wrap it up. Yep.
Yep. Rosie, and everyone, great suggestions. I have to tell you right now, I'm this person. I'm a person living with pain. I've been living with pain since 2009. This was me before I learned. I went through formal pain rehabilitation at the Mayo Clinic Pain Rehabilitation Center. And before I started self-managing my pain, I no longer use any biological interventions for my pain, pharmaceuticals or injections, none of it. I self-manage by not focusing on the pain, like Rosie mentioned, by not worrying about the pain because I know the pain means me no harm, and making my life bigger than the pain. And so those are the things that have changed my life.
Thank you so much, Tom. And Tosin will put in the chat, along with the video that Dan shared, which is really going to be helpful, some resources to support that Tom has created, actually, patient education materials and so on. So thank you so much, Tom. We appreciate your courage and bravery to do this. And we hope that we didn't really, nobody feels betrayed or duped by this presentation, but it's such a great example of how somebody can really be resilient and really pull above by going through, not around, but going through the really hard stuff that's related to chronic pain. So thank you, Tom.
Thank you. Accepting is so important.
Janice, could you put your question in the chat, because I want to honor time for Daniela's presentation as well. So Daniela, your turn.
Okay, great. Wow, Tom, thank you so much for sharing that. That is so courageous. And I hope that we were all compassionate. And I think that I was talking about different things about descriptive diagnosis, and I hope that it wasn't in any way not compassionate or anything like that, because my whole presentation today is about how to use patient-friendly language and how to be compassionate and how to introduce this topic to your patients. So I'm a licensed clinical social worker. I've been working with patients suffering from chronic pain since I was in grad school. This is definitely a bit of a shift from the first presentation, and I'm so glad that I got to hear from Dr. Berlin about some of the medications that can be helpful to patients. It's an area of knowledge that I definitely lack and want to hear more about. So thank you, Dr. Berlin. After working with patients, kind of like Tom, and seeing so much success using pain reprocessing therapy and seeing the need for more education in kind of the nuances of how we work with this population, I went on to co-found the Pain Reprocessing Therapy Center. I was involved in building the curriculum for a 21-hour certification program where we train and certify both medical and mental health professionals in how to use this modality of therapy. So far, we've trained about 2,000 professionals. Recently, we began offering groups, like kind of these group psychoeducational workshops for patients so that they can learn more about primary pain. I'm also involved in the second clinical trial of pain reprocessing therapy. If any of you were here a couple of weeks ago when my colleague John Gasenica spoke, he kind of reviewed the first clinical trial, which was published in JAMA Psychiatry and proved the efficacy of PRT. Our second clinical trial has 2 experimental groups. One is PRT and the other one is CBT. And I am really excited about that. And Almost forgot my most important work, which is that I'm a mom of 3 little girls. So today we're gonna, like I said, talk about how to introduce PRT with patients in a simplified and compassionate way. So John, again, just mentioning John's presentation, he talked about it from a more scientific perspective, and today we're gonna get more into the clinical aspects of it. So to recap, PRT is an evidence-based therapy to treat chronic pain. It's kind of the system of techniques that is aimed at retraining the brain to interpret signals from the body more accurately. And we use PRT, or pain reprocessing therapy, in its entirety only with patients who have primary pain, meaning that their pain is not stemming from a physical issue or a disease, but rather the misfiring of pain circuits in the brain. So with this population specifically, it's really important to build rapport. You want to listen to their pain story. You want to ask follow-up questions. You want to really validate their experiences. And I know that in some of your kind of practices, there isn't a lot of time for this, but what are some ways that you can ease it in and build rapport and be compassionate in a very quick and efficient way? And you keep in mind that this population is so often, stigmatized and dismissed, and, may come to you already with a distaste for the field and with their guards way up. So building rapport and taking the time to really build, some type of trust in the relationship will increase the likelihood that patients are going to be open to hearing, novel concepts that may almost sound to them like you're telling me it's all in my head. And patients are kind of more open to receiving feedback or direction if they believe that you really understand their condition. So really take the time to ask a lot of questions and get to know their pain story. Okay, next slide. Okay, so before we talk about the things to say to patients, I want to talk about some of the things that our patients so often hear and things maybe not to say. Okay, so number 1, the pain is in your head. First of all, all pain is generated in the brain, no matter what. So I think it's kind of funny that people will say the pain is in your head. Yeah, all pain is in the head. It's all generated from the brain, whether it's an accurate reflection of physical damage or not. The pain isn't real. Also, not true. The pain is always real, whether it's an accurate reflection of physical damage or not. Another thing is just try to ignore it. Some of the things we were talking about before of refocusing your attention, that is different than saying, oh, just try to ignore it, right? Because it's really hard to ignore pain because pain is an alarm system. It's there to tell us that there's something wrong in our environment. So it's really hard to just ignore it. I was once having a session with a patient and I had a scented candle right next to me, and we were talking about these concepts of, pain is an alarm system. It's there to warn us of danger. And I had my scented candle going, and I have a smoke detector right above me. And all of a sudden in the middle of our session, my smoke detector starts going off. And I'm like, okay, I gotta go check what's going on. I need to end the session. I need to just check to make sure everything's okay. And I knew that it was from my candle. Like, I saw it burning right next to me, but still, you can't just ignore an alarm system. All alarm systems, whether it's an accurate reflection of threat or not, sound the same. And so it's really hard to just ignore it. Another thing that a lot of people will say, and I know that, all, doctors and all of us in this field, we're all coming from a place where we're well-meaning. We want to help our patients. But when we say things like, there's nothing I can do for you, that can feel like so much of like a death sentence, like an add to this feeling of hopelessness and despair, and there's nothing that can be done for me. And how can we reframe that? Can we say something like, fortunately, there's nothing that we can do from a biomedical perspective because you're strong and you're healthy. But hey, there's so many really new, evidence-based treatments for chronic pain that have proven to be effective. And then you can go into explaining what you think is going on. And the last thing is saying you're just going to have to learn to manage it. It's not true. We actually can treat it. With our PRT first clinical trial, 98% of the people improved, 67% were pain-free or nearly pain-free. And so it's not that you have to just manage it, you can actually get out of pain. And that can bring a lot of hope. Okay, next slide. Okay, so now that we discussed, hold on, is that the right one? I think we skipped over something. Okay, maybe not. Okay, now that we discussed kind of what not to say, what can we say? So the first thing I like to reinforce is that the pain isn't entirely bad, right? Pain's role is to warn us of danger. Like I said, it's necessary for survival. There are actually people who can't experience pain, and not surprisingly, their life expectancy is pretty low. So something I like to tell my patients is, pain is really good. We need it, because imagine you were running on a broken ankle. You would experience pain that would inform you, okay, stop running, take a break so that you don't cause tissue damage. Same thing with, let's say we put our hands on a hot stove. You would experience pain that would inform you to move your hand so you don't cause any damage, so that you don't injure yourself further. Okay, next slide. But sometimes these danger signals can get activated even when there's nothing wrong. Sometimes we experience pain when there is no physical threat. And this happens all the time to everyone, not just people with chronic pain. And I like to say this to normalize this experience. Think about getting a stomach ache before public speaking, or getting really nervous and anxious before taking a test. We all have these physical symptoms, even in the absence of threat. Okay, next slide. What I find really helpful with patients is to use a ton of analogies. I throw all the analogies at them. So, here are two analogies that I really love to use. So I'll say something like, danger signals can get activated even when there's no threat. It's like if we were playing catch and I were to throw you a baseball, but you thought it was a hand grenade, you'd react as if it were a hand grenade. You'd run away, you'd jump back. The same thing as if imagine you went out into your yard and the garden hose was right next to you and you thought it was a rattlesnake. You would react as if there was a threat. And that's what happens with primary pain. Your brain is reacting to a neutral stimulus as if it is dangerous, even though it's just a neutral baseball or garden hose. Next slide. Okay, so what's going on is that when we believe that there's a threat, the brain can generate pain. And the power of the brain and the power of belief is really astonishing. Pain is a combination of sensory input, what we feel, and our internal predictions, what we expect to feel. The New England Journal of Medicine actually talked about a story about a construction worker who was on the job and he jumped on a nail. And he was in immediate agony. He saw the nail go right through his shoe and he's in agony, and the ambulance come and they take him to the hospital and they pry off the boot and the doctors come. And what they notice is that the nail didn't even cause a scratch. It went straight between his toes. It didn't even harm him. So yes, he felt the neutral sensation of the nail maybe going through his toes and maybe, touching, the sensory receptors on his skin. But the prediction, because of the belief that it went through his foot, was able to produce a huge amount of agony for him. Lorimer Moseley talks about something like this also. I can share with you his TED Talk if you haven't heard it yet. I don't think we have time, so let's move to the next slide. Another thing that I like to tell patients is I talk about an amplification of symptoms. So sometimes people will have, I think like Tom, what you were talking about having symptoms that don't necessarily match up to what is seen on an MRI. So maybe there is there should be a level 2 of pain, but you're feeling at almost like a 10. So what I like to say to my patients is, for example, let's say I'm sitting right here. You're sitting right there. Maybe one of you have back pain, but I don't. Yes, there's neutral sensations that are going through my back right now. I'm putting pressure on my back and my brain is going, oh, just a light sensation, just some pressure on the back. This is totally safe. This is completely neutral. But then for some of my patients, it's a horribly painful experience. And the way that I explain it is, imagine you were wearing a hearing aid right now, and the thing that determines, whether the volume knob gets turned up or down is how much danger does your brain think it is. So maybe, for example, right now I'm talking at a 2 out of 10, but you're wearing a hearing aid and you're hearing me at a 7 or 8 out of 10. It's because that volume knob is turned up all the way. And that's what's happening with your back. The volume knob is turned up. And what is the thing that turns up the volume? Next slide. Is fear or threat. When our brain believes that there is fear, that there's a threat, then it produces pain. So pain equals sensation plus fear, or pain equals sensation plus threat. And so the only thing that we need to get rid of in order to make it just a neutral sensation again is to get rid of the fear, is to eliminate that sense of threat. Next slide. So fear can be kind of a triggering word, and that's why I sometimes use the word threat. But I want to say that fear kind of can encompass any kind of felt sense of threat. And the way that we look at it is, fear around the symptoms. So what Tom was describing as, or Rosie, that preoccupation or that Googling or that constantly checking. So it's those fears around the symptoms, those beliefs around the symptoms, the fear that it's going to get worse, or why was it worse yesterday or better yesterday? And then the second idea is fear in general, threats in general, things in the environment that can, make us feel more threatened. So for example, being on disability and, having to quit your job, and what's going to happen if I'm in pain, and what's going to happen to my relationships, and am I going to isolate myself? And so all these other threats can almost amp us up to this experience of that volume knob being turned up. And another analogy, because I'm just constantly throwing analogies, is imagine you're watching a horror movie and, when you watch a scary movie and then all of a sudden every single noise that you hear will make you feel like there's like an axe murderer around the corner, because oh my God, someone could just touch you on the shoulder and you blow out of proportion. So that's kind of what it's like when we have a felt sense of threat in our environment, maybe not necessarily having to do with our pain, but maybe, anxiety or depression or a relationship issue or losing our job or feeling, hopeless. That puts us in horror movie mode. That makes us more amped up to threat and more susceptible to interpret sensations through a different lens, kind of through a lens of danger. And when we talk about fear can encompass so many different words. Some patients will say, but I'm not afraid of my pain. No, but there's, you're thinking about your pain, you're anxious about your pain, you want it to go away, you're annoyed, you're frustrated. All of those things can make you in more of a state of high alert. Okay, next slide. And that kind of brings us into this pain-fear cycle. So the more preoccupied, the more fearful, the more frustrated, the more we fuel the pain, the more we fuel it to stay. And then the more fuel it has, the more pain, and the more pain, the more fear. And it goes kind of on and on. Next slide. So in all circumstances, when you're talking to your patients, you want to talk about, the fact that there's so much research about all of this, and every single patient is going to be different. So if you get someone with back pain, you're going to want to bring them studies about back pain. And, I can't go too far into this, but in our longer course, we talk about all the different studies, and you really want to figure out a way to listen to their story, build rapport, explain this to them, and package it back to them in a way that is relevant to their situation and something that makes them feel like, yeah, this is me. This makes a lot of sense, right? And there's been a lot of research showing that, learned neural pathways in the brain can actually cause most forms of chronic pain. Okay, next slide. And the last part is discussing treatment as this two-pronged approach. So we're going to work with your fear around the symptoms, your thoughts, your behaviors, your fears, your beliefs around the symptoms themselves, but also your relationship to fear and threat in general. So that horror movie mode of feeling hypervigilant, of feeling in a state of high alert, and how all those things can perpetuate symptoms. And when we learn to take away that idea of fear, pain equals sensation plus fear, then all we have is sensation, and we teach our brain to interpret it correctly. Okay, I'm going to end for now. Any questions or comments?
That was so fast, Daniela, so much, but I hope people really got this whole notion of a cycle, and that it's interruptible. And I like the notion of a lot of metaphors, and we do have I think John shared a number of studies in his presentation, and we have others that will be in the slides from your presentation, as well as Dan will add the YouTube video that you gave us. And what else? There's a great. So we can stay on the line for a few minutes more. However, I just want to say for those who do need to leave that we do, in order to receive your CEs, you need to complete the sign-in sheet and you need to complete the evaluation form. Tosin has put everything in the chat for you. Our next session is next week, and Dan will be back to talk about how pain medications may help or, oh, there's a typo on that side, may help or harm. And we have Dr. Dolores Blackwell, who's going to be giving us more insight into the PHQ-9 and the GAD, the PHQ and the GAD assessments. You know, they're just such a routine part of the healthcare delivery system, but what does it really mean, and how can you use it to make meaning and circle back into what Daniela is talking about? Also on the next slide, just best practices, these are resources. Carolyn, could you keep going? These are the, oh yeah, keep going. Go one more. Keep going one more. Yeah, right here on the iecho.org is the website for all of the materials for this session. So all the slides, all the recordings of all the other prior sessions, and today's recording will also be posted there. The slide deck is already there, and Carolyn is showing you that you click on the name of the series, IPRO Echo When the Pain Won't Stop, etc. And then when you click on that, you'll see the list that looks like this. And then you just select the session that you want to get the materials from. Lisa, thank you so much for helping us get that right for your physician colleague. We appreciate that as well. Okay, so that's the housekeeping on the Evelyn Wood version. Daniela, questions or comments for Daniela for those who want to stay on, if anybody has any? Daniela, thank you also very much for that. It was really
I
so
apologize
fast.
for the fast pace. I just kept noticing the time. Oh no.
I know it's such a challenge, this short amount of time. I do think Dana brought up an interesting point earlier with Tom's case about the religious or the spiritual support, and that's such an important component to that also gets blown by in assessments. You know, when you're doing an assessment with a patient, you know, a religious affiliation or some question like that, and people don't know what to do with that information. And Dana, I just wondered if you had anything that you wanted to just touch on that because you brought that up.
Well, thank you for hosting. It's a pleasure to be here. Dr. David is actually one of my professors at University of Maryland Eastern Shore, or former professor. And my research partner and I presented on this topic related to pharmacy patients in community practice settings, because in many cases there may be restrictions based on a person's religious or spiritual affiliation for certain ingredients in medication therapies that they may not want to take advantage of. And the Joint Commission does require that hospitalized patients are given a survey. And can you hear me okay? I'm using these earbuds, and okay. But we don't have anything when we are assisting patients in other pharmacy practice settings, particularly ambulatory care or community. And we want to be able to honor their spiritual and religious needs, because then patients, you know, we all know, right? Adherence is a difficulty. And as presented earlier, sometimes patients will not take a medication, they'll experience a side effect, or they'll find that perhaps the frequency of medication or some of the ingredients are not something that they want to include in their lives. And it may have something to do with a spiritual or religious affiliation. So the other part of that is just having community. Sometimes that community support can help people to remember what is important to them and perhaps help them to calm some of the triggers that are resulting in the experience of pain. And so that's what brought me to ask.
I appreciate that response. I hadn't thought about the ingredients of medications. I totally, that's like a, oh yeah, of course. So thank you for that. That's great. And it is we in our planning committee conversation, we had several conversations about the role of religion or spiritual community, whatever that is, for people, why that's important in a chronic management of a chronic illness, and chronic pain in particular. But it's just really offers oftentimes a source of hope and hang in there-ness kind of thing. Like you said, Dana, like just really a sense of community. You're not alone kind of thing, which it can be really isolating. So thank you. All right, Daniela, other questions for Daniela, or comments, or just what do you wonder, like, what are you thinking about with that? Carol, I didn't know if you had any thoughts, or Tom, Sarah. I'm just picking on you all because your beautiful faces are right here in front of me. Just don't have to say anything. Tom, go ahead.
Sure, I've got my hand raised because Daniela hit the nail on the head when she's talking about fear of pain. And it's one of the things that I talk about in my support group with the members of my Chronic Pain Champions No Whining Allowed support group, and in my free book on my website. The fear of pain is worse than the pain itself. And pain is just a sensation. Exactly, is just a sensation. And I think that's so important to share that with people living with pain, that they don't have to worry about it. And I wish a doctor would have told me earlier in my pain journey that I had chronic pain, instead of searching for a cause and cure for the pain and teaching me how to manage the pain, self-manage the pain, to change my pain experience like Danielle is talking about, that physically to change the whole experience. Thank you very much.
Thank you.
This is Carol. Not really a question, but when she was talking about sensation plus fear, I was sitting here nodding and remembering my right big toe. I had surgery on twice for ingrown toenails. One of those times was a very painful experience because the physician did not allow the anesthetic time to work before he started cutting. And even now, I mean, I was 14 or 15 when that happened. So this is 60 years later. That's the toe that if I bump it, I will have to fight crying. Whereas I did 5 vaginal deliveries without pain medications, no sweat. So it is that fear that, just bumping my toe on something and I'm in pain. And I have to calm myself down and look at it and go, it's not injured, it's okay.
Great. Thank you, Carol. Other questions or comments or thoughts about either what not to say or how to educate and to inform patients?
Daniela, I like the fact that you use compassion rather than sympathy, or but it's compassion. So compassion leads to self-teaching and self-training. Sympathy. My husband used to say you can find it in the dictionary between 2 words, but sympathy. Most people with pain don't want you to have sympathy, but they want help with their pain. And being compassionate and understanding and helping them understand their pain is the most compassionate way you can do it. I'm an amputee, so I deal with phantom pain and very severe phantom pain. And because of that, there's nothing that helps that. Because when I laughed when you said it's in your head, because that, phantom pain is only in my head. There's nothing there to be painful anymore, so I laugh about that all the time, because it really taught me that pain is generated in your head, because it definitely isn't there to be generated in my leg anymore, or my hip. So I think that's one of the, and I think the other thing is that we learn to deal with pain at different levels. I have dislocated my left hip several times, and before I started having severe phantom pains, I thought that was the worst pain in the world, was dislocating your hip. But I dislocated it a couple of weeks, about just before Christmas, and I kept thinking, boy, this isn't that bad a pain as I thought it was the first times I had it. So I think it's one of those things that pain, you learn of pain tolerance, and you learn to tolerate it better, because you're not as afraid of it as you once were.
That's like such a power of the brain to produce these sensations and to amplify these sensations. And I think you're so right about, showing compassion is the right word. And it's not sympathy, and I think that part of, I'm coming from a therapeutic perspective. So I'm very, into modeling different behaviors. And if I can model compassion, then maybe they can turn that compassion inward. And if I model confidence, and I know that you're healthy and I know that you're strong, maybe they can borrow that confidence from me until they can build it on their own.
Right.
Dylan, did you want to say something?
I think I'm okay on that. I think it was answered by her talking. So I appreciate you guys.
Thank you. Any other? Just I want to make sure everyone has an opportunity to say what they want to say before we end it all. Oh, okay. Well, hearing no others, Daniela, thank you so much. Thank you all for hanging in with us. Jerry, I hope maybe there's a seed that's planted in this conversation today. I don't know what it is, but for just a seed planting.